Well, when it rains, it pours. The world has to deal with yet another variant of COVID-19 as the IHU emerges, which has 46 mutations. Now, with Omicron now in 100 countries and the Delta variant still raging in some parts of the world, IHU is yet another addition to the jigsaw of this virus. Scientists have said the variant is not of concern yet, but is that enough to hold? What are we yet to know about the IHU? Is COVID-19 here to stay? The questions are enormous and endless, and we'll be looking to unpack some of these on The Square. Welcome, I'm Sulaiman. Well, another variant of COVID-19 has been discovered in France and named IHU. The new B16402 variant is so far reported to have infected 12 persons and has 46 mutations. In the case of viruses, that's some strong potential potency. The index case of the virus was a vaccinated adult with travel history to Cameroon in Central Africa. IHU had been discovered since as early as November, but it showed no signs of virulence. It predated Omicron, but never posed as close to a threat to the variant. With little to no epidemiological, virological, or clinical basis to its presence, the IHU still stays on the fringes of COVID's most dangerous variants. The WHO says it has always been on its radar, but had very little chances to pick up and be as transmissible or as virulent as other variants. Is IHU one to be cautious of? Is there a cause for alarm? Let's find out. Good to see you today. Joining me, Dr. Kemisola Agbaoye, who is the Senior Program Manager at Nigeria Health Watch, and Dr. Peter Imoesi, a research fellow at the University of Aberdeen, Scotland. Good to see you, ladies and gentlemen, and a fantastic new year to you both. Let me start with you, Dr. Imoesi. I'm starting with you because close to the end of the year, we had you on the show, and I specifically asked if we have seen the end of, the variants, and you did say that there's every likelihood that there will be more. And here we are today talking about IHU variant. What can you tell us about the IHU variant?
Thank you for having me. I think with the IHU variant, we are seeing now, it's like you said initially, we've got just 47 mutations with this particular variant. When you look at the mutations we're seeing with the IHU, we know that it shares the same common similarities when it comes to the mutations we've seen over time. Number one of that is the E484 mutation. And that particular mutation across all of the variants we've seen enhances this variant to escape antibody vaccine-induced immunity when it comes to the antibodies you have. So that particular mutation is present in the Alpha, Delta, Omicron, and currently in this IHU variant. So technically, when you look at the mutations, clearly we know what the functionalities of all of these mutations, what they represent. So I think we're in a better place right now to know that the mutations we are seeing, these are the likelihood of what they can do and what they can't do. But for now, how virulent with this particular variant is, we don't know. That is one. Then when it comes to the level of transmissibility, we don't know, because we know currently that Omicron is the most dominant variant around the world, alongside Delta variant in some pockets or some areas of countries around the world. For now, I think we just have to keep an eye on the IHU and see how things unfold going forward in the coming days or months as it is.
Well, Peter, as we keep an eye, let me quickly bring in Kemi here. As we keep an eye, as Peter said, but let's ask, looking at what is happening around the west of Africa, specifically Nigeria, Dr. Kemi, help us here. The index case, though, had a travel history to Cameroon. Is there a need to be cautious considering the Africa Cup of Nations coming up in Cameroon and the possible presence of the French and how Nigerians have this, closeness to even the Cameroons?
Absolutely. I think that we need to remain cautious. We need to continue to adhere to the public health measures, the proven measures that have worked so far. One of the things that would be worth considering, particularly for not just Nigeria, but all African countries, is making sure that all of these measures are active at points of entry. So it would be that would be the efforts, and making sure that the players that travel and all their everyone who goes with them is tested and vaccinated. Like the other doctor said, it's something to keep an eye on because of the mutations, even though it's not yet a variant of concern or even of interest for that matter, based on the WHO classification. But yes, given the coming travels, the coming Africa Cup of Nations, public health measures need to be adhered to strictly to prevent as much spread as possible. But I mean, the one case that's been identified is still currently in France. And so far, I think there are only 12 identified cases. Maybe with genomic testing and some further investigations, some more cases might be found in Africa since there was a history of travel to Cameroon. But until we know all of those, I mean, it's still quite early. Until we know all of those, what we know works are the public health measures, vaccination, and we should stick to those.
Now, so stick to those. Yes, too early in the day, but again, let's quickly start looking at lifestyles and look at how Nigerians and Africans are dealing with this. I recall, Dr. Peter, I also recall close to in the Yuletide, during the Yuletide, we specifically talked about a possible spike. And I'm quite sure you've been following the figures from the NCDC in Nigeria. That's a very worrisome increase in the numbers of those who have the virus. Does this have the potential? Now, looking at that, what has happened, and talking about the IHU, there seems to be the potential for this to be as transmissible as the Delta variant or the Omicron.
Yes, there is a possibility. So I think the problem we've got in Africa or in Western African countries is our level of genomic surveillance. I've said repeatedly on several platforms that when it comes to the variants that we know, I think there are many we don't know when it comes to West African nations, for instance, in Nigeria, because when you look at the adherence to the non-pharmaceutical interventions, we are not really top-notch in that area. And this kind of measures will always lead to the breeding of new variants in your own country. So if persons are not really adhering to these rules and people do what they like on a daily basis, then you create a platform for the emergence of new variants. That is one. Then also, when it comes to the uptake of vaccines, we know that when it comes to vaccine uptake in West Africa, Nigeria to be specific as well, the uptake of vaccines right now is really low. So we have high level of COVID-19 vaccine hesitancy in the country. So given all of these issues on ground, it's just that maybe because of our own kind of demography when it comes to the population we've got in the country and on the continent, that may kind of play a role in the kind of fatality we were seeing on the continent and as well in Nigeria. But again, when you look at this particular IHU variant and you compare the mutations we are seeing with the Omicron, with Delta, with Alpha, it has a potential to actually lead to a high level of transmissibility. Well, also when it comes to the Omicron that was initially detected in South Africa, people were saying that that particular mutation is mild, variant is mild. But again, we know that when it comes to the age demography in South Africa, the age demography is really low. It's a youthful population. So until all of these kind of variants make their ways into the West, for instance, in the UK or in the US, where they've got a different age demography, That is when we can actually tell the impact of all of these variants coming forth from countries with low vaccination rates. So I think we actually need to kind of increase our surveillance, at the same time increase our testing capacity. I know that when it comes to testing in Nigeria, we're not really doing very well, because when you look at our testing numbers, today they are high, tomorrow they are low. So it means that we're not really consistent in the way we do our testing. And that also speaks to the genomic surveillance as well. When it comes to the genomic surveillance, we're not really following through the samples in the country. And what that means is we're actually lagging behind in the actual variant in the country and on the continent as well.
Well, this truly should worry every African or Nigerian listening to you now. Can you help us here? Because, it looks so, so worrisome to see that the people would wake up and, sometimes try as much as possible. I'm trying to look at what Peter has said. Vaccine hesitancy is still there, very much there. What are we not doing right as a people to ensure that people, get vaccinated? We'll come back to looking at the variants. Can you help us here? What are we not doing to convince more people to go get the jab?
So first off, this isn't a new problem. The health-seeking behavior I'll speak for Nigeria, has always left a lot to be desired. People would rather go to a chemist or, go to, say, a traditional medicine practitioner to get help than to go to the hospital. And it translates to this as well. We have a lot to do in terms of social and behavioral change communication, in terms of getting people to see that orthodox medicine is good, to actually convince people. So that said, the vaccine hesitancy is driven by a lot of misinformation out there, and it's not unique to Nigeria or Africa as a whole. I think that Western countries have also had they've also had to battle some of the misinformation and, put measures in place, put incentives and measures in place to get people to take the vaccines. I know of countries who went as far as letting some of their staff go, putting them on suspension if they refuse to get the jab. So for Nigeria or for Africa, we need to start to think innovatively of measures and methods that we can put in place to get people to overcome the vaccine hesitancy. For example, at Nigeria Health Watch, we conducted a survey sometime last year, just exploring people's attitudes and how people saw the vaccine and whether or not they would take it. And one key thing that came out of that survey was that people's health-seeking behavior was directly tied to how hesitant they were to take the vaccine. It was their health-seeking behavior, it was their access to information, access to misinformation, so to say, because people who lived in urban areas, who had access to the internet, who had access to social media, were, funny enough, less likely to take the vaccine than people who lived in rural areas, who had already had some kind of exposure to orthodox medicine and to vaccines in the past. So methods and measures that combine all of these, that look at influencing health-seeking behavior, that look at combating misinformation, that look at making healthcare more accessible, making those vaccines more accessible. I know that we have had quite a very, our uptake of the vaccines we do have has been low. So that also brings that's another layer to the problem, really, making sure that the vaccines that we do have are utilized and that they get to people on time, reducing waste. All of these measures, all of these things speaking to this, they all influence the issues that we have with vaccine uptake and, increasing the rate of vaccination in Nigeria and in Africa as a whole.
I'm excited about this survey by your group, Nigeria Health Watch. I'll come back to you, Kemi, so that we can talk more about that survey, the outcome, and some of the key things that you've been able to get for us. Now, Peter, IHU, I remember then I did ask about the naming of these, variants. We'll talk about the variants, but again, it's yet to be tagged a variant of concern, isn't it? So walk us through the process, Dr. Peter, of naming a virus as a variant of concern?
So when it comes to if the variant is going to be named as variant of concern, you have to look at the level of dominance of that particular variant within a particular location. Say, for instance, in France right now, let's say IHU is taking over the entire country, then World Health can say, okay, this is more likely to be a variant of concern. And then you have to have a look at that particular variant closely. That is one. Then two, you also have to look at the way it spreads around other countries as well. A case example is the Omicron. You know, when it comes to Omicron, it was first detected in South Africa. And within weeks, it took over the entire South Africa. And from there, we saw the way it jumped into the Western countries, for instance, the UK, the US, and other parts of the world. So based on the level of transmissibility and how far this particular variant can spread, then you can say, oh, this may likely be a variant of concern. But I think before now, this particular variant, I think the first time it was detected was sometime in April. And it has been under the radar of WHO to see the way it's going to play out. And I think now we've recorded about 157 genomes of this particular IHU in the GSED database. So the GSED database is a platform where many scientists around the world deposit these sequences as they see changes with the particular SARS-CoV-2 virus they are tracking over time. So I think for now, like I said, we have to watch to see the way things plays out. That is one. Then two, when it comes to the nomenclature of this particular variant, of course, we'll go by the Greek alphabet, and that will be based on what WHO intend to do based on the naming. And from there, we'll see what the name of this particular variant is, and let's see how it's going to play out in the next coming days or weeks. But I think for now, Omicron is actually taking a full grip of many countries around the world. So let's see if IHU will outcompete Omicron in the next weeks or months. Well, no one can tell exactly how this is going to play out in the next months or weeks to come.
Before I go to Kemi, quickly here, you've always maintained your analysis on the low testing capacity here in Nigeria as against what obtains in the UK where you are. And let us in on, the risk or the danger of having that, because I think if you place a call to some of those here in Nigeria, you hear stories of, oh, it's the weather. I have this cough, I have this cold. It's a change in weather, it's the Harmattan. And I said, hey, come on, this is getting more serious than what we used to know about the change in weather. Let us in on the testing, capacity of the virus at the moment in Nigeria.
I know when it comes to the RT-qPCR, it's a little bit complex and it's a little bit expensive as well. So I'm not surprised that many countries around the world are really struggling when it comes to the RT-qPCR testing. But there's a rapid diagnostic testing as well that I think Nigeria should adopt going forward. And we've got that here in the UK, which is a lateral flow test. And that same test allows you to pick or detect the cases quicker compared to the RT-qPCR. Again, when it comes to the RT-qPCR, that is more precise and very sensitive and accurate.
Sorry to come in here. Is there a way you can break it down?
So the RT-qPCR is the normal PCR you hear every now and again. So if you're trying to actually confirm if an individual is positive, the most accurate form of detection, which is a gold standard, is the RT-qPCR, which is the PCR you hear in the media. And that particular kind of techniques requires high level of specialty training of experts and also high standardized reagents. So the problem we may likely run into with the RT-qPCR in Nigeria, which we did in the early days of the pandemic, is sorting for the reagents you need for this particular testing. That is one. Then two, these reagents are really expensive. Then three, I'm not sure we have R&D companies in Nigeria with the capability to manufacture or to produce these reagents in Nigeria. So it means that you have to depend on importation from countries around the world. And based on this kind of bottlenecks and issues here and there, that will actually limit the rate at which you are able to do your testing over a period of time. So that is one aspect. So first, the qPCR are really expensive. But the other way we can go based on our own kind of population is to adopt the rapid diagnostic test kits. These test kits are really simple to use. You could use them within your home, within your offices. It's really simple. It's more like the usual HIV or pregnancy kind of tests that within 15, 20 minutes, you have the results. Despite they are not so accurate, but they can still give you a fair understanding of if people are positive or if they are negative. And that is the area we need to look into. I think in the early days of this pandemic, one of the key messages from WHO was we need to do testing, and continuous testing. Only that can we tell where we are in the pandemic and how far the virus is going within your own population. Fine, it's good enough to see that people are not dying in Nigeria or in Africa. But again, we know that the longer this virus stays in the host, which is the human host, for a long period of time, the more chances the virus have to create more mutations. And these mutations, if they are kind of beneficial to the virus, the more the virus will have the capability to invade the immune system, either from the vaccine-induced immunity or from the natural immunity as well. And that is why we need to understand the behavioral pattern of the virus. Where is the virus? How is the virus behaving? What is the number of people within your country who are testing positive on a daily basis? And based on this sort of indices, we can tell clearly where we are in the pandemic and how we're able to track down these cases. But I think in Nigeria, this is really a difficult task for the government because one, like Dr. Kemi mentioned, the behavioral pattern of our people when it comes to response to the healthcare system is not really there. And again, you know, in the early days of the pandemic, there was a prediction by doomsayers saying, oh, people are going to be dying on the street of Africa. But because this sort of predictions didn't really come to play, people are kind of relaxed by saying, oh, after all, we're not dying. So of what purpose is the vaccines? Of what purpose is me going out to get my sample or get myself tested for possible SARS-CoV-2 infection? And based on that, we're going to have this variant popping up every now and again until we put our house in order to ensure that everyone buy into this pandemic. I think we're really in a long time when it comes to this particular SARS-CoV-2 pandemic we're in at the moment.
Well, I think that says it all. We'll come back. Before we go on the break, let me allow Dr. Kemi let us in on some of the key things done by the Nigeria Health Watch. And I also see from your site, going through your site earlier on, that you were also able to recapitulate what happened in the year 2021. And top on that list is COVID-19 and the vaccine, which was this, gifted to the world by scientists like Dr. Peter. Let us in on what your group is doing.
Right. So we are a not-for-profit organization that aims to influence or just make health be higher on the public agenda using informed commentary and insights. So we do a lot of writing. We put out outputs in different formats, including video and editorials as well. One of the interesting things we did over the COVID-19 during the COVID-19 pandemic was to use multimedia methods to combat misinformation around COVID-19. And we've gone from breaking down how the vaccines were developed, because one of the dominant misinformation that we saw out there was that people thought the vaccines came out way too early, way too quickly. And so it couldn't be safe to take. So we did a breakdown, for example, of how long it takes and what steps you need to go through to produce a vaccine. And we put out a video on that and we shared that on social media. We're very big on social media advocacy and, raising awareness and educating the public using social media. We also went to TV and radio and used that to help to combat misinformation. For the survey, it was conducted, like I said earlier, to understand people's perception about the COVID-19 vaccine and to see how hesitant people were, to see how willing, let me say the positive part, see how willing people were to take the vaccine before the rollout commenced in Nigeria. And we asked questions around what their health-seeking behaviors were, and we found correlations between that and whether they were willing to take the vaccine or not. We also asked questions around whether they had taken vaccines before, what media they use, or what media they consume health information from, where they get their health details or healthcare from, for example. And all of those and we compared those we compared those in rural and urban communities. And one of the things that came out from that is how complex our terrain is, and how really steeped into the culture and the tradition it is, the poor health-seeking behavior, the need for people, or the insistence of people to not go to hospitals. And until we look at the vaccine hesitancy and the vaccine rollout issues with a wider lens and try to tailor it to our environments, to our country, and our very unique problems that are long-standing, that have been there before, we might not make as much progress as we want to. It would involve we would have to involve traditional leaders, for example, religious leaders. There were people who said they wouldn't take the vaccine because, their pastors hadn't taken it, or their religious leader had said something about it not being safe. This is Nigeria, or this is Africa. I mean, what happens in Nigeria seems to be really similar in other African countries. Our issues are quite different and vast and complex. I mean, to take all of those into consideration to help us move closer to coming out of this pandemic. Like Dr. Peter said, it's not been so bad here. A lot of people haven't died. But then what we don't understand is that disease surveillance usually just shows you a tip of the iceberg. It's just a small bits.
I quite understand. Yeah, I don't mean to butt in here, but I quite understand the picture. And I'm smiling here because it took me a while, having this series of shows with Dr. Peter before I was able to get out of my Thomas, enclave to take the vaccine. But now, Peter, here, quickly before we go on the break, the index case was vaccinated. And we've seen cases of people with full vaccination and booster dose still coming down with COVID-19. So how much of a novel virus is COVID-19?
This is 2022. Yes. I wouldn't say SARS-CoV-2 is novel anymore, because we do know a number of characteristics when it comes to the virus. Well, people are vaccinated. A number of persons are coming down with the infection. But I want to look at this from a different perspective. What if we had no vaccines now? What would be the outcome when it comes to the level of fatality across many countries in the world? So we know in the early days of the clinical trials, the three endpoints for the vaccines anyway were hospitalization, death, and severity. And so far, so good. The vaccines are holding their grounds when it comes to stopping those three endpoints. Before we had the Delta variant, the vaccines had the capability as well to limit transmission when it comes to the Alpha variant. But the good news is, if you're vaccinated, for instance, the time lag in which this particular virus is going to stay in your system is limited to a number of 3 to 5 days before you're able to clear it off from your system. Whereas for individuals who are unvaccinated, for instance, they may likely take a longer time to clear off the virus from their system. And of course, you never can tell what's going to be the repercussion of you getting exposed to SARS-CoV-2 and having the virus to stay in your system for a long period of time, like we are seeing with brain fog and long haulers as well. So far, so good. I would say we are in a better place, and the vaccines are doing what they are meant to do. And with the boosters, we're seeing a significant impact when it comes to reduction in the level of severity, hospitalization, and death as well. So I think so far, so good. We are actually in the right position right now when it comes to the vaccines.
All right, again, that's a fine place for us to anchor this. We'll come back. When we come back, we'll talk more about the vaccine, talk more about Omicron, and see what more Africans and the world should be doing to fight COVID-19. Well, if you just joined us, you're welcome. You're watching VSA here on News Central Television. And so far, not much has been said about the IHU, with 47 more mutations than Omicron in IHU. Scientists say the failure of the world to have vaccines spreading out in a fair manner will lead to more variants and more problems. The more opportunities a virus has to spread, the more its mutations and possibly its variants. Now, the dangers of these variants may differ, but they are better avoided. Omicron today is battling many countries in the world, although at little to no severity, and some countries are still facing the twin challenge, the Delta variant and Omicron. So far, IHU has yet to be reported anywhere else but France, and its ability to be a bigger problem still unknown. It is important that it is stopped before it spreads. Still have Dr. Peter Imoesi with me here, and of course, Dr. Kemisola Agbaoye with us. Is the home run here, quickly here. Let's start talking about some other key things. Dr. Kemi, help us here. You know, a continent like Africa, where many predicted so many deaths, isn't facing it. But the continent holds the potential of having many variants. Listen to both of you. Are you convinced that with research, we may be seeing more variants even in Africa?
Well, yeah, I think that's that is possible. Like Dr. Peter said earlier, the lack of not consistent, but enough testing and a lack of adherence to the proven non-pharmaceutical measures and hesitancy to take the vaccine. All of those just provide such an enabling, in quote, environment for the vaccine to continue to mutate and to continue to have more variants. So yes, I think it is possible that unless we do something, I mean, the vaccine hesitancy also works hand in hand with issues around vaccine equity and making sure that the vaccines are available. And we've had governing bodies, key organizations such as the Africa CDC in Africa work towards battling vaccine equity. There are lots of organizations working on vaccine hesitancy as well. But beyond that, I think one key message that needs to be at the forefront of the public agenda, that needs to keep being communicated to everyone, is how important it is to adhere to the non-pharmaceutical measures of wearing a mask. I live in Nigeria and everyone has relaxed. Over the holidays, over the Yuletide season, you would hardly find people wearing their masks, observing physical distancing or social distancing. All of these measures need to be adhered to. I know that, for those, while the number of people who have had COVID-19 is most definitely much larger than the number of cases that have been reported, people think that because the symptoms that they've had or the severity of the illnesses that they've had hasn't been so bad, they think that it's not such a bad thing. I've heard people say we need to get used to it. It's like malaria. While that is true, we don't want to be so relaxed that the next terrible variant pops up in Africa. And then it turns out that it has built all of the mechanisms that it needs to start to really affect the predominantly young population in Africa. We don't want that to happen. And we know that the public health measures that we have been lauding out there significantly help to reduce transmission. If you can reduce transmission, then you can, at the very least, mitigate the virus's mutations and help to, take us closer to stopping the pandemic. So we won't stop saying it, and we won't stop saying how important it is to get vaccinated if you have access to the vaccines, and to continue to adhere to the public health measures.
So Peter, I decided to allow Kemi start off that for us, because you had spoken about this earlier, and it looks to us that the continent is low. There's little or none, form of research in that area. Speak to that, and also see if you can also let us in on the danger of having the virus staying in a body for too long.
I think when it comes to research, it depends on the research culture of the people. So are we really interested in research? That is the first question we should ask ourselves as a country and as a continent. I know South Africa are doing their best. The same goes for Rwanda, Kenya, and countries within Northern Africa. But again, if we lack this particular human resources when it comes to research, we can't really tell the peculiar situation of what is going on in Africa. And we have other pockets of issues when it comes to endemic kind of diseases on the continent that we should research on as well. So research is actually key when it comes to driving the health system of any nation. And until we invest heavily in that area, we train our best brains and we retain these individuals within the continent, then we kind of will be at the mercy of the so-called developed countries around the world. So first and foremost, we need to lay emphasis on research, and the real importance of research should be well spelled out to the government and to those in authority. Now, when it comes to us not knowing if this virus is so dominant among our population and the implication of that when it comes to mutations, we know that in the early days of this particular mutations we're seeing, specifically for the alpha variant, we were told that this particular variant at the time emerged from a chronic individual who had a particular disease. Now, when you have individuals with immune who are compromised when it comes to their immunity, or who are also on particular drugs that suppresses their immune system, what that means is that your level or your strength in which your immune has the capability to fight off a particular disease is weakened over time. And if that is the case, it means that the virus has the capability to stay longer in that particular host. And the longer the virus stays in this particular individual, the longer the virus has the capability to replicate and replicate over time. Now, we know already not all of the replications or not all of the mutations we see are key or are beneficial for the virus. However, the virus will always select for the best. And for instance, that is where you have your alpha, delta, kappa, gamma, and all of them. So if this virus, for instance, is staying longer, not just in a particular host, for instance, let's say it's staying longer among your population, moving from one individual to another, and to another, what you're doing is you're allowing the virus to pass through your population, then learning how to invade your young population as regards to Nigeria, for instance, its age demography of 22. So in the end, we may likely have a variant that will be highly specific to our own demography. And at that point, we may likely not be in a better position compared to other parts of the world. And you saw what happened in the early days of Omicron when it was detected in South Africa, the way other countries shut their doors against Africa as a continent and many other African countries. And that is my worry. I don't want us to be in a situation whereby we have a peculiar variant in Africa that other countries will say, you know what, let's close this guy out of the way and let them deal with themselves. And again, I know we have more than 50 million vaccines in Nigeria, and these vaccines, people are not really coming forth to take these vaccines as it were. So for me, I think we need to change the public health messaging. Again, the vaccines, we need to tell our people that it's not enough to say we're not dying. There are other issues associated with COVID-19 when it comes to the disease. So you don't want to have your population with high level of disability in the next 5, 10, or 15 years. And that should be the core message. Research and also the real reason why people should come forth to take these vaccines going forward.
Well, Kemi, you know, I recall when we had the index case in Nigeria, February of 2020, and we decided to do all the tracing. The index case, in this case, traveled to Cameroon. Is there any likelihood that we're looking at possibly going back to places he visited and conducting a level of research there? Could Cameroon have a variant, maybe like Nigeria, they don't even know of yet?
Absolutely. Yes, absolutely. So it's called contact tracing. He was in Cameroon. I'm sure if the IHU variant is identified in Cameroon, then there's a pretty good chance, there's a chance that he probably got it there. And if he did, then it means that he could have, been the source of transmission for a few other persons as he traveled. So I think that, well, genomic surveillance and genomic testing needs to be really strong everywhere. It's already, we do a lot of genomic surveillance here. It's how we identified that we had the Omicron variants and the Delta variants when they were all identified in Nigeria. Cameroon needs to do that at this point because there's a history of travel from their country, and there hasn't been any other cases identified anywhere else. All the 12 cases in France were linked as contacts of this index case. And if Cameroon needs to do that surveillance, needs to do the testing and to confirm that the IHU variant is in there, then it means that many other countries, particularly African countries, need to do the surveillance as well. They need to check to ensure that the IHU variant is in there, including Nigeria. There's a lot of travel from Cameroon to Nigeria, direct flights, some travel from Cameroon, from Central Africa, if not Cameroon, Central Africa to Nigeria. And it could have gone and spread faster than we think. So yes, it is possible.
All right, okay. Peter, less than 6% of, sadly so, the continent population is vaccinated. It goes back to the vaccine conversation before the break. And we're looking at possibilities of herd immunity. How long will it take most African countries or the world, if possible, to achieve this?
It depends on the route you want to go through. Is either you're trying to go through the route of vaccine-induced immunity, or you want to go through the natural infection. And I think last year, the NCDC in Nigeria did a seroprevalence study among number of states in Nigeria to see the level of infection when it comes to people within each state. And that particular infection rate was not really significant to say, oh, we have a significant level of herd immunity. And I think many countries around the world are not really going through that particular route right now. The reason for that is if you keep having variants that are popping up every now and again with the capability to invade your vaccine-induced immunity, the possibility of saying we're reaching herd immunity is, I think, is a firecracker when it comes to herd immunity itself. For me, I'm not really a proponent of herd immunity, because when you look at the behavioral pattern of the virus, it's really difficult to say, oh, we're going to reach this particular level. That is one. Also, we know that over time, 6 to 8 months, we have a waning immunity with the vaccines. And if your immunity is waning out, and then at that particular edge, you have a new variant, it means that you have to run back into your shells to look for new measures to combat that new variant, as it were. So for me, the real message is, let's go on with the vaccines we have right now. Let people come forward to take these vaccines. And until people are willing to come forward for the vaccines, then we can say, oh, we have a high level of uptake of vaccines within many African countries. For instance, I think in Nigeria, we've not really hit 7 or 10% of uptake of our population when it comes to 200 million people. And on the continent, we have 1.3 billion people on the continent. And when you look at the statistics of people that have taken the vaccines is not really encouraging to say. So I think for now, I won't really rely on herd immunity. What I want to rely on is giving out the message to people for them to understand why they need to take the vaccines. And from there, we'll see how this plays out in the next months or maybe 2 years from now. People are saying this may likely take longer than we expected in the first instance. So I don't know if that particular herd immunity is going to be achievable anytime soon.
And Peter, quickly here, is it safe to say the virus, with the presence of vaccine in some of those that have been vaxxed, is also fighting to see how it can actually break down the system?
I hear this a lot, but that's not the case. First and foremost, because you're vaccinated, you have immunity already. So if you're exposed to the virus, it means that you have your little soldiers ready to fight off that particular infection. So the time line in which that particular virus will stay in your system will be shortened immediately compared to people who are unvaccinated. So I won't really say, oh, the virus is trying to look for ways to invade the vaccine-induced immunity. Of course, the virus is trying, but the vaccines are holding their grounds. But there are persons that, even though they are vaccinated, they may likely not mount a significant level of immunity. And those are the immune-compromised individuals. And that is why we need to actually encourage a number of persons to take the vaccines to protect the set of individuals over time.
Okay, Kemi, I'll come back to you, Peter. Kemi, how do we couch the message? Because I'm trying to look at what you're doing. Your Health Watch should also, weigh in helping Nigeria and even the NCDC, couch the message succinctly in the language that these people will understand. These people, us, everyone, and say, hey, wait a minute, you do need the vaccine.
Absolutely. How to couch it? It's basically couching one simple message that addresses most of the concerns that people have.
I know I'm asking a PR question to a doctor, so don't get me wrong here, because you are the expert. It looks like a lot of Thomases there, people still not believing in it.
Absolutely. It's to say that the vaccine is safe, and it's to be honest and clear about what the vaccine does. You've mentioned on this show that people who have been double vaccinated, even had boosters, still came down with COVID-19. The clear message is this: that the vaccine it doesn't necessarily prevent you from contracting COVID-19, but it does reduce the chances of having severe illness, being hospitalized, or dying. The 3 endpoints that Dr. Peter referred to earlier. It's making sure that the messaging is clear and it's honest and backed by research, by current research. I think that one of the mistakes we probably made at the beginning was to not be honest and direct about how much we know. Sometimes you want to encourage people too much because you think, oh, yeah, let's just push people to go get it for their good. But at some point, for example, the US had said their citizens should stop wearing masks if they were fully vaccinated. And they had to go back on that because it became clear that people who had been vaccinated could still not just contract COVID-19, but transmit it as well. And if a vaccinated person contracts COVID-19 and has mild symptoms because you're protected from severe symptoms, from hospitalization and from death, and you pass the virus to someone who hasn't been vaccinated, who is immunocompromised, for example, or who has underlying conditions like hypertension, that person comes down with severe illness, and that just compromises the health system that we're trying to, strengthen, and the transmissions that we're trying to reduce. So being clear and being honest and being factual about our messaging should cut it. Combating misinformation, you can only combat misinformation with the existing research, with what has been proven and what we do know, and being honest about what we do not know yet. For example, at first we thought the vaccinations could last, say, we didn't know how long it would last. We didn't know if it would last a year or not. And then we found out, the vaccine becomes less effective after 6 months, so take a booster. For Johnson & Johnson is after 2 months, take a booster. So yeah, I hope I have answered your question.
Perfectly well. And perfectly
is
so.
the messaging that we need.
Yes.
Yeah.
I got three things there. We must be fair, we must be factual, and we must be honest. And that honesty definitely will resonate with the people. Quickly, as we wind down, help us here, Peter. I realize that some who have come down with the virus didn't have you remember in 2020, people would say, I suddenly lost my sense of smell, my sense of, taste. It looks like the variants are changing. Does Africa hold the threat of seeing more variants without vaccination? And how is it that things are changing as we're moving on with the variants?
I think each variant is actually having their own peculiar clinical manifestation, and that is actually kind of deceiving the population. So today we have a variant that you have loss of smell, taste as well. But with the Omicron, I think it comes with kind of sore throat, body fatigue, slight headache, and runny nose and what have you. So it's kind of mimic the usual flu-like symptoms we see during the winter in this part of the world. And again, I would say that the real messaging, like Dr. Kemi mentioned, is that we need to know that people who have the virus in their system do have a number of issues that may likely come forth in the nearest future. Number one is your developmental capacity when it comes to your brain. Like I said on this same platform some days ago, where I said there's a study here in the UK that did a brain scan of people who were mildly or moderate to severe infected with SARS-CoV-2, and they saw a significant reduction in their gray matter, which is the brain. So for me, I went for the vaccine not because I don't want to die. I went for the vaccine because I want to have my brain faculty intact. And that should be the message for our population, that we are not dying, but we need your brain faculty intact. So go for the vaccine to ensure that you avoid brain fog and long haul. That's the key message for Africa, not death.
I tell you, that's a fine place for us to leave it today. Go for the vaccine, and so you can be a whole person with your right senses. Well, many thanks, Doctors Kemisola Agbaoye and Peter Imoesi. It's a delight speaking with you both, and I'm hoping that we can come back again and have this conversation. We need to keep informing the people, talking to the people as well, and seeing how much we can gain by saving the continent come the world. As we all can tell, COVID-19 is still very much around. Variants keep emerging. You've heard from the experts, and you should stay safe and protect your families. Many thanks for watching. I'm Sulaiman.